I'm Dan Durrie, and I'm an ophthalmologist from Kansas City. And I've had the pleasure of working with the Visometrics technology really for the last 7 or 8 years. And it's really nice to see it coming to this level where we're actually talking about it at meetings rather than just as a research tool. One thing a lot of my colleagues ask me is, what is this HD analyzer? What does it do, and how is it different than some of the equipment that we use all the time in the practice? And it's not like an aberrometer or a topography device, and it really has a different purpose. But the HD analyzer is the most recent unit from a company called Visometrics from Spain. And I've used their tools in our research department for quite a few years, and what we're using them for was to measure something that we couldn't measure otherwise, which is the scatter of the optical image as it goes into the eye. So I like to tell patients this is something that doesn't measure nearsightedness, farsightedness, astigmatism. It doesn't measure the shape of your eye, but it looks at any scatter of light as the light rays go through your tear film, your cornea, and your lens, and picks that up for us and gives us that piece of information. I'm not an engineer, so a lot of times I can't really tell people how this works, but essentially the best way to think of it is there's a low energy laser ray that is sent in the eye, and it bounces back, and the machine will read any of that light that was lost or scattered. So that's when I usually put this in patient terms, is that what light didn't make it back as it goes through your optical system. So what it's doing is it's measuring that electronically, and then with fancy software it gives us a reading that we can help explain that to patients so they can understand their vision better. I think that the biggest thing about this is it simplifies the way to get this information, because at a slit lamp, if you're really looking carefully, you may be able to see the scatter of the light in the tear film. You may be able to see by a little bit of increased density in the beam of the slit lamp that the cornea is a little denser. You may be able to look at the lens in the eye and say there may be some scatter of light there, but it doesn't give you an objective measurement, and we certainly can't compare it from one doctor to another one. So this gives you an OSI reading, which is your optical scatter reading, and it gives you a score. And through all the work that Pablo Artel has done in their lab in Spain and some ARVO posters, we know if it's at a certain level, we know that the vision's going to be good and have good quality, and at a certain level we know some of the signals being lost as it goes through the eye. So it gives us a score. We can compare it from one doctor to another one. And more importantly, we can compare it with a patient from one visit to another one. So it gives us kind of that score we can kind of work with. One of the things that I have found now, since I use this on every single patient that I do evaluation on, whether it's a totally healthy patient coming in for LASIK surgery who's 18 years old, or somebody that's in their 50s of presbyopic, or somebody that's coming in complaining about the quality of their vision, what it gives me is this extra piece of information to let me know, is the light being scattered when they go through their eye? Say if somebody has vision quality complaints, or saying things are fuzzy. Well, if I do an HD analyzer on them and get an excellent reading, a really good reading, I know it's not in their tear film or their cornea or their lens. And I've ruled out a whole lot of problems, so I've got to look at their retina and make sure there's not an epiretinal membrane, or there isn't something going on that's deeper in the eye. A normal reading in the population of this, which keeps it simple, is 1.0. If somebody's better than 1.0, they have really good optics. If they're worse than 1.0, I've got to look for a cause. So that's kind of a nice little cutoff. So this gives me a piece of information so that I can help diagnose the problem, and even more tell the patient what and why we're doing something to try to make it better. One of the things that's been really nice about this is the software is very good as an educational tool. So I not only get it on every patient, it's right in the screen in the room, so I can actually show them along with other data that I'm showing them of what's going on with their eye. And they really like it. Matter of fact, several times I've had patients that have had visual complaints. I have poor quality vision, or I have halos, or I have frostiness in my vision. And I've showed them their HD analyzer and I say, that's it. That's what I see. And I've kind of, when I talk to my colleagues sometimes, this is the first instrument that really shows us how people see in their quality. You know, and there's lots of other things can be wrong with the eye, so it doesn't solve all problems, but it really kind of sorts us out so we can explain this to patients. So I really like that when we can take something out of the lab, into the clinic, into some box, but now we can bring it right in front of the patient to help them understand their eyes better and let us fix their problem better. One thing that when we use this tool in a research format, we only used it in clinical trials. And I've used several clinical trials. We've been able to help improve products along the way as a research tool. But the big breakthrough is when the HD analyzer came out, which used to be called OCUS. It was the term that some people have heard of this. But the HD analyzer now is a commercially available unit that's easy to use. All my staff knows how to use it. There's no problem getting pictures. So now I use it on every patient. For a while, we were using it on some patients and we found out we had to send people back for an HD analyzer because I'd say, gee, I'd really wish I had one on that patient. So now part of it is just like doing a manifest refraction, doing a topography, checking their corneal thickness. We just have it in our routine. So the doctor, when they're making decisions about patients' quality of care, we have it every time. We don't get it on every post-op exam at the 1 week and 1 month, you know, like we did in research projects. But anybody who's coming in with visual complaints or coming in for a complete exam or coming in for a follow-up exam years after surgery, we use it on all those patients. One thing that's interesting that we found out, and that's what's fun about watching the development of these instruments, we had this real problem with getting a good reading with the original OCUS Visimetrics device. It was that when somebody stared at it, and if they had dry eyes, we couldn't get a good image. So I started talking to the engineers and saying, could we use this for an advantage? So in a very quick fashion, they put together a tear film analysis part of this. So what we essentially do is have people stare at the machine for 10 seconds. It measures every half second. And if somebody doesn't have dry eyes, the image quality stays the same for that whole 10 seconds. If somebody has dry eyes, then the image quality decreases as they're staring at the device, and then it even graphs it out so that you can kind of see their vision quality go down. So then I can put somebody on Restasis or some medication, bring them back and say, did I do anything to improve it? Because now I have an objective measurement of dry eyes. So it ended up being a problem with the machine. The dry eyes got in the way, and we kind of flipped it and made it to an advantage. One thing I've found now, and I think the place that's really helpful for me, is in two contrasting areas, and this is really helpful. One is my patient who comes in for LASIK surgery. And I can look at them and say, okay, if I'm going to correct your nearsightedness and your astigmatism or your farsightedness, what target can we shoot at? And what I can tell now is somebody has excellent optical quality. Their tear film's good, their cornea is good, and their lens is good. I can get a reading from this, but it'll actually tell, it'll convolve the image, it'll give me a points fed function, it'll give me MTF, it'll give me a Strel ratio, and those are all neat for scientists. But it really tells me, I think I can make you better than 20/20. Okay, and that's what the patient wants to hear. Or I can say, I can make you better 20/20 in your right eye, but you have some scatter from that little PSC cataract in one eye, and I can't in that one, and I can show them the difference. So in my LASIK practice, it's really valuable because it tells me what expectations should my patient and I have. And I know with my excimer laser and on the things I've done, I can deliver getting rid of nearsightedness and astigmatism and some farsightedness. But I needed that variability on which patient could I put their expectations high versus low. The other part of the practice is, which is when people start developing what we're calling the dysfunctional lens syndrome. Dysfunctional lens syndrome is kind of a new term that we're using now, but if you take people that are in their 40s, something happens to their lens and they can no longer focus up close. but that's stage one of the dysfunctional lens. There's a second one that really happens in our 50s where the lens starts getting denser. It turns a little bit yellow. We call it nuclear sclerosis, but to the patient, their quality of vision is going down, and this easily picks that up, that they're coming in and they're not just having problems with the first stage of losing their near vision from presbyopia or lack of accommodation, that they moved to stage 2, and now they're starting to have some vision quality of it, and stage 3 is a cataract. In my practice, hardly everybody ever gets a cataract because we replace their lens when they get to stage 2 of the dysfunctional lens syndrome. So what that does is, say if I have a 50-year-old patient who comes in, wants to see better, I'm going to do HD analyzer and tell me, do I go the corneal laser route or do I replace their lens? So this is really valuable on that. And a lot of times if somebody's coming in thinking they're going to have LASIK surgery and I tell them they need their lens replaced, it isn't like they're going to have it done tomorrow. This is a whole new educational thing, but I can show them objectively, this is the reason why I'm suggesting this. And then, since lenses keep getting worse, maybe I'll see that patient a year later. We'll do their HD, now it got worse. They said, okay, I don't want to watch this train going down the hill. I want my lens replaced. And we've objectively documented that their lens is getting worse. So it's been really helpful in providing better care to patients to be able to tell us what procedure to do and when to do it. And there's a lot of trust factor that's developed that this machine's kind of helping us make that decision. Because before we just kind of look at their eyes and say, your lens is going bad. And they kind of say, well, you know, I don't have a cataract, do I? No, you don't have a cataract, but you're going to get one someday. This one gives us a good objective reading to kind of explain that to them. One of the things that's starting to float around amongst my colleagues, and the HD analyzer is really driving this, is ocular scatter. We've never talked about it before. You know, we couldn't measure it. We kind of knew that lights get scattered from your tear film and your cornea and your lens. But now we've got a new term to talk about is we've got our ocular scatter index, our ROSI measurement that comes out of the machine, and I'll be talking to somebody about a case, and if they have the machine, I'd say, what's their scatter? And so it's just a new term that we're starting to talk about because we've got a measurement device that can find it. Always been there, but it's neat when electronics kind of makes our communications, discussions just better and easier. And this machine is really easy to use. You know, I mean, all of our technicians use this machine. So it's not like we have to call the photographer in to do this machine or somebody that's a specialist. It's very easy to use, and everybody likes it. It's one of the easy tests. They wish a lot of my other tests were as easy as this one.